Adolescent sexual and reproductive health is a global public health concern, and therefore we need data that can be used to monitor how countries are progressing in addressing adolescent sexual and reproductive health issues. Demographic health surveys, or DHS, which are conducted every 5 years, have been the major source of information in sub-Saharan Africa. Performance monitoring for action, or PMA, have been conducted annually since 2014 to monitor contraceptive use in 11 countries, of which 9 are from sub-Saharan Africa. In addition to contraceptive use, the PMA collects data on fertility, marriage, and sexual behavior. In this study, we assessed how the PMA can be used to improve adolescent sexual and reproductive health monitoring. We selected countries with at least 3 rounds of national representative PMA surveys and 2 recent DHS surveys as of January 2020. The selected countries were Ghana, Nigeria, Uganda, Ethiopia, and Kenya. Our analysis in the paper focused on 4 indicators, which were sexual debut among unmarried adolescent girls, ever married adolescent girls, ever given birth or pregnant before marriage adolescent girls, and contraceptive use among unmarried adolescent girls. In this presentation, I will share results for adolescent births before marriage and contraceptive use. We first compared the PMA and DHS survey tools in terms of how they collect data on fertility and the 4 indicators. We also compared the differences in the sample sizes and the clusters and the response rates, and also the representation of adolescent girls. Although PMA surveys do not capture birth history as comprehensively as DHS surveys, there was no substantial effect on the results. The DHS number of clusters were at least 3 times higher than those in PMA, and hence the sample size. The response rate was between 94 to 99% in all countries for all surveys, and close to 20% of the interviewed women of reproductive age group were adolescents in all years of both surveys. In this slide, I present the percentage of adolescents who were pregnant or had given birth before marriage. We see PMA estimates being consistent over the years, though somewhat irregular for Uganda and Ghana. Except for Nigeria, PMA and DHS estimates are close in all countries, with Ethiopia and Kenya having a perfect match. Thus, the PMA results give us a clear picture of the status of adolescent parenthood in these countries. As you can see in the graph, we observe high percentage of adolescent births before marriage in Uganda, and this is close to 30%. And these have remained stagnant since 2013 to 2018 in both surveys. We also observe declining trends in Kenya for birth before marriage. In this slide, I present results on modern contraceptive use among unmarried sexually active adolescent girls. We observe some inconsistencies between DHS and PMA data in Kenya and Nigeria. Nonetheless, the PMA results give us a picture of contraceptive use among adolescent girls. In Uganda and Ethiopia, we observe decreasing rates in contraceptive use, and as of 2018, it was estimated at 26% for Uganda and 50% for Ethiopia. In Kenya and Nigeria, we observe increasing rates in contraceptive use, and as of 2018, it was estimated at 35% in both countries. While in Ghana, we observe a stagnation in contraceptive use that is estimated between 20 to 24% over the years. In conclusion, we found no systematic issues with PMA surveys for adolescent sexual and reproductive health indicators. Therefore, these surveys can contribute to monitoring adolescent sexual reproductive health indicators more frequently. The main drawback are the larger and variable sampling errors in PMA surveys, which has to be considered in the assessment of the recent trends. The smaller sample sizes of PMA surveys make it impossible to examine the inequalities in adolescent sexual and reproductive health. However, pulling the data for 2 to 3 years may give us a sufficient sample size.